Hello everyone, it's Ryan Beck, fellowship trained orthopedic surgeon here at the Orthopaedic Institute of Western Kentucky, talking to you about total hip replacements today, specifically that in the outpatient setting. The hip is probably the most notable ball and socket joint that we have in our entire body, and the second most commonly replaced joint that we see here in the United States behind total knee replacements. Very common. You may have known someone or even have a total hip yourself, and here today to talk to you about the intricacies of it and make it not such a scary or daunting consideration if you or your surgeon has come to the conclusion that a total hip replacement is right for you. Unlike the shoulder, which is technically a ball and socket but has a very unconstrained joint, and we talked about in previous videos where that ball has a freedom of motion due to a lack of bony constraint, the hip joint or the acetabulum is a constrained hip joint and therefore has a lot of its constraint based on the bony confines of the socket that the femoral head or the ball of your ball and socket finds itself in. Unfortunately, being a weight-bearing joint similar to the knees, this joint can wear out over time. We know that it has a strong familial connection. There are whole lineages of families that have cartilage wear out faster than others. True environmental can play a role in that if you do have a very laborious job or find yourself doing things in squatting position or repetitive over and over again. And then finally, post-traumatic. I have people who come in all the time who've had an injury early in life, sustained to one of their hips, and then the injuries have succumbed to cartilage loss over time, and then they are talking about total hip replacement, sometimes even earlier than they would have anticipated based on their age. A final consideration is I do see a lot of people with avascular necrosis where they've lost the blood supply to their femoral head, and that has caused early degeneration of their hip. Regardless of what situation you find yourself in, you may be considering the possibility of total hip replacement, and I'm here to kind of talk you through some of that. Most of the providers here employ the anterior approach, that is approach over the front of the hip, different than some of the posterior or lateral approaches that you may have come to be familiar with in years past. That has been traditionally the approach employed by most surgeons until recent years. But here at the Orthopaedic Institute, we do anterior approach, and unless otherwise deemed necessary by your provider. And what that does is that allows us to spare the musculature. We do not have to cut any of the muscles approaching your hip joint, different from some of the other approaches that have to be employed. And therefore, you're ready to use your hip the moment that you wake up from surgery. That may be something divergent from what you've heard or what some of your loved ones or friends have gone through in the past. But with new and advancing technologies and techniques, we now have patients up, walking, and ready to go home an hour after their surgery. It's remarkable, it's wonderful. You get to convalesce at home, you get to convalesce away from an institutionalized setting. It minimizes your risk for infection. There are a bunch of perks that may be appropriate for you. And again, if you're not one of those patients that finds yourself an optimum patient profile, or you have other considerations or comorbidities that need to be validated by treating in a hospital setting, you may find yourself in a hospital setting, and that's totally fine. The surgical approach will be largely the same for you, and the intraoperative progression, again, very similar. I have here a model of what your total hip replacement looks like on your right half of this. This is a translucent model to simulate what your prosthesis would look like on an x-ray after your replacement. And on your left, this is kind of the anatomic consideration of what your hip joint might look like leading up to it. Unlike the posterior approaches where we had to take down the musculature to gain access to the hip joint and then repair that musculature after replacing the joint, the anterior approach that we now utilize will allow us to spread, now this comes apart, but it allows us to spread these muscles out of the way and gain access to your hip joint without ever taking down any musculature whatsoever, so that your muscles are ready to be utilized the moment you're waking up from surgery and ready to start using your hip. Ideally, your hip joint, smooth, continuous cartilage with good contact point, no bone spurs, no points of impingement, that allows you to walk what most of us take for granted on a daily basis with every step. Unfortunately, over time or after trauma or with other considerations, that cartilage becomes degraded and is eccentric, and in some cases you can even lose the round morphology of your femoral head, and then you no longer have a round ball and a round socket. You may have a flattened or ball in your socket. And that's when hip replacement would come in. Ideally, we would be replacing the ball with the ball and the socket with the socket. This would be your mobile bearing surface. Unfortunately, we can't just sit a ball on your bone. We need some way to affix it, and so we place it on a femoral stem that gets placed down in your femur. And I have found with most of my patients, this is the point of most contention with patients. They're worried about this piece of metal being within their bone. It is entirely housed within your bone. It is not outside. It does not irritate your muscles. It does not cause irritation or reactionary, and it gives your body a chance to incorporate and grow around this implant, creating more prominent fixation as weeks progress from surgery. The acetabulum, the socket, as we saw in that previous model, also gets worn out, so we can't just leave it as is. We have to replace it. So we put an acetabular shell in your native socket and then replace it with a bearing surface, affectionately known as plastic, but it's actually highly cross-linked polyethylene, which makes a very resilient mobile bearing wear interface, giving you a newly congruent round ball and round socket after completion of your surgery. And based on fixation, this implant and this hip is stable and ready to be used the moment that you are. So outpatient total hip replacement is now no longer this nebulous or unknown. It's something that we do routinely on a regular basis, and something that you can take confidence in, that if you've been identified by your provider or myself as a patient who is safe, healthy, and capable of doing something like this, you can go into that facility, hospital, otherwise, with the confidence that your hip is bad and it's getting ready to be made better, and you're ready to use it the moment that you wake up. Thank you, everybody. This is Ryan Beck, Orthopaedic Institute's fellowship trained orthopedic surgeon, talking about total hips. Hope you have a blessed day.